Hi, welcome to my vlog, and this is skills versus capacities of a back squat and a Nordic exercise. This first athlete is demonstrating the ability to perform a back squat. It is possible to see that the athlete has various movement restrictions and compensations, which therefore demonstrates joint capacity issues affecting an ideal back squat performance. In this anterior view of the squat, the athlete shows a non-parallel bar position as a result of right side flexion of the trunk. The athlete also shows interesting behaviour of the right and left hips. It is possible to see right side femoral external rotation, left side femoral internal rotation, and also valgus at the left knee. This results in the knee pointing beyond the athlete's big toe on the left side. This is also the result of excessive pronation of the left foot. It is also possible to see that the right knee has a different finishing position in the descent phase of the squat. This is possibly due to a lack of hip flexion, knee flexion, or ankle dorsiflexion capacity. When looking at the same athlete from a posterior view, these issues are further evident. As the athlete gets deeper into the descent phase of the squat, the athlete avoids right hip flexion. This may suggest a femoroacetabular impingement or other significant hip pathology which is being avoided. Considering this, the athlete reduces squat depth on the right side, but also demonstrates hip external rotation on the right side and right side flexion of the trunk to try and establish as much depth of the squat as possible. Furthermore, the posterior view provides a better view of the left foot and its excessive pronation. The athlete gets better squat depth on the left side, but is possibly restricted into ankle dorsiflexion, hence a compensatory excessive pronation of the left foot. The movement restrictions of the right hip and left ankle are key capacity issues, which result in multiple compensations and affect the ideal performance of a squat in this athlete. There may be further motor control and skill issues with the squat, such as hip internal rotation control on the left side, but it can be argued that by resolving the capacity restrictions of the right hip and left ankle will help the skill issues. Furthermore, restrictions in squat depth have led to a lesser knee flexion angle and promote a forward lean strategy. An intervention to improve hip flexion could be to provide external transverse traction to the hip while the athlete moves into flexion. However, if there is significant hip pathology, the athlete may need to be referred for medical opinion. Similar strategy can be used to improve ankle dorsiflexion, with both techniques used to improve arthrokinematics of the joints. This next athlete demonstrates a motor control or skill issue when performing a back squat. From this lateral view of the athlete, it is possible to see that the athlete initiates the movement with an acceptable hip hinge strategy, but very quickly performs a forward lean strategy and does not utilise full hip flexion to get the depth in the squat. This results in a large amount of lumbar flexion in the deeper stages of the squat to try and achieve that range of motion. This may cause added shear force strain on lower lumbar segments, especially when lifting heavier. This forward lean strategy negates a drop into hip flexion and therefore decreases the amount of knee flexion achieved. This strategy also limits the activation of gluteus maximus, adductor magnus, and also the hamstring muscles, which can be seen in deeper positions of the squat. One way of retraining the athlete away from a forward lean strategy could be through a pole squat technique. This encourages the athlete to drop back into the space between the athlete's legs, encouraging a greater depth of the squat. This also takes away any concerns over balance when sitting back into deeper positions of the squat. The next two athletes observed show either capacity issues or skill issues when performing a Nordic hamstring exercise. The first athlete performing a Nordic shows adequate hamstring strength to perform the eccentric muscle activity that the exercise requires. However, to achieve this, the athlete utilizes various adjustments in technique. From a lateral view of the athlete performing the Nordic, it is possible to see that the athlete puts themselves in a slightly hip flex position. The athlete also utilizes excessive lumbar extension to achieve co-contraction of the hips and pelvis throughout the movement of the Nordic. This could possibly be due to motor control deficits of the lumbar pelvic hip complex, specifically underutilized inner range gluteus maximus, external obliques, and overutilized lumbar extensors when trying to keep the hip in a neutral to extended position whilst performing the Nordic in a kneeling position. This could be something that the athlete's habitual strengthening routines has reinforced over time. From a posterior view, the athlete starts and finishes the movement with a right side tibial external rotation and a slight lean to the left. Once again, I believe this is due to a motor control issue which has been a learned technique over time. Tibial external rotation of the right side suggests a neuromuscular imbalance between the lateral hamstrings and medial hamstrings. However, the athlete's force remains strong and consistent, as seen on the force curves. The difference between left and right may be due to the athlete's technique of leaning to the left slightly. Interventions to address the motor control issues discussed in the athlete could use similar exercise which encourage tibial internal rotation and medial hamstring recruitment, and also exercise progressions which encourage posterior tilting of the pelvis and inner range gluteal activity. In turn, these may help with the forward lean and the excessive lumbar extension seen on this athlete during a Nordic exercise. The next athlete shows a significant hamstring capacity issue when performing a Nordic exercise. The athlete shows a good starting position, but is unable to complete the required eccentric range of the Nordic exercise and fails very early in the movement. This suggests that the athlete is not yet strong enough eccentrically to cope well with the demands of the exercise, which can also be seen in the force trace. The athlete also tries to utilize a tibial external rotation strategy on his right side. This may also show an early skill issue with the athlete. This is something the previous athlete demonstrated, but the previous athlete was able to cope well with the eccentric demands of the exercise. A possible intervention to improve the hamstring capacity of the athlete could be to continue performing the exercise, but with some banded assistance. By providing banded assistance, the athlete will be able to perform the exercise through a better range and spend longer time under tension. This, performed as part of their strength program, will provide an opportunity for muscle hypertrophy and improve motor control of the exercise. Additionally, the athlete could perform isometric hamstring strengthening in different ranges of knee flexion to aid neuromuscular adaptations of the hamstring musculature. So that concludes our capacity and skill issues of a squat and Nordic exercise that we discussed. I'm hoping a few key messages from the athletes that I've discussed is that I think understanding the capacity issues is important for technique, as the compensatory movements to overcome the movement restrictions could be detrimental to performance of the skill. However, if skill issues are ignored, this may lead to movement restrictions down the line as part of a habitual learning process. Also, it was apparent in most of the athletes that both skill and capacity issues were seen in conjunction with each other. Understanding the most dominant issue may, however, improve the other.